Inflammatory bowel diseases, IBD, encompass a group of chronic conditions that involve inflammation of the gastrointestinal tract. The main IBDs are Crohn's disease and ulcerative colitis, both characterized by periods of inflammatory activity, called flares, interspersed with periods of remission. Although the exact causes of these diseases are not fully understood, it is believed that a combination of genetic, environmental, and immunological factors plays a crucial role in their development. In Crohn's disease, inflammation can affect any part of the gastrointestinal tract, from the mouth to the anus, but it is most common in the small intestine, particularly in the terminal ileum. This inflammation can penetrate all layers of the intestinal wall, resulting in complications such as strictures, narrowing, fistulas, abnormal passages between different parts of the intestine, or between the intestine and other organs, and abscesses. The symptoms of Crohn's disease are varied, including abdominal pain, chronic diarrhea, weight loss, fever, and in some cases rectal bleeding. Malnutrition is also a significant concern due to poor nutrient absorption. Ulcerative colitis, on the other hand, is limited to the colon and rectum. The inflammation primarily affects the innermost layer of the intestinal wall, the mucosa, causing ulcers and erosions. Typical symptoms include bloody diarrhea, abdominal pain, urgency to defecate, and tenesmus, sensation of incomplete evacuation. In severe cases, ulcerative colitis can lead to toxic megacolon, a severe dilation of the colon that requires urgent intervention. Both conditions share some symptoms but differ in the anatomical distribution of inflammation and the depth of intestinal wall involvement. IBDs are chronic diseases and currently, there is no known cure. However, effective treatments are available to control inflammation, relieve symptoms, and prolong periods of remission. These treatments include anti-inflammatories, immunosuppressants, and biological therapies, which have revolutionized the management of these diseases in recent decades. Genetic factors play a significant role in the risk of developing IBDs. Studies show that first-degree relatives of individuals with Crohn's disease or ulcerative colitis have an increased risk of developing these conditions. Several genes associated with the immune response have been identified as risk factors for IBDs. Among them, the NOD2 gene, also known as CARD15, is strongly associated with Crohn's disease. Polymorphisms in this gene can lead to an altered immune response to intestinal microorganisms, contributing to chronic inflammation. Environmental factors are also important in the development and exacerbation of IBDs. The Western diet, rich in saturated fats and refined sugars, has been associated with an increased risk of IBDs. Smoking is another well-established environmental factor. It is a risk factor for Crohn's disease, but interestingly seems to have a protective effect against ulcerative colitis. Urbanization and higher socioeconomic status have also been correlated with a higher risk of IBDs, possibly due to lifestyle changes and exposure to microorganisms in childhood. The gut microbiome, which comprises trillions of bacteria and other microorganisms that inhabit the gastrointestinal tract, is closely linked to gut health. Alterations in the composition of the microbiome, known as dysbiosis, have been observed in patients with IBDs. These imbalances can trigger an abnormal immune response, promoting intestinal inflammation. Ongoing research on the microbiome is opening new possibilities for targeted treatments that aim to restore a healthy microbiome. The innate and adaptive immune response is fundamental in the development of IBDs. The innate immune system is the first line of defense against pathogens, while the adaptive system mounts specific and long-lasting responses. In individuals with IBDs, there is a dysregulation of these systems, leading to a continuous and inadequate inflammatory response. Immune cells such as T lymphocytes and dendritic cells play crucial roles in perpetuating inflammation. Pro-inflammatory cytokines such as TNF-A, IL-1B, and IL-6 are found at elevated levels in patients with IBDs, being targets of many current therapies. The diagnosis of IBDs involves a combination of clinical evaluation, laboratory tests, endoscopy, and imaging. Endoscopy, including colonoscopy and enteroscopy, is essential for directly visualizing inflammation, collecting biopsies, and assessing the extent and severity of the disease. Imaging tests, such as magnetic resonance imaging and computed tomography, help identify complications such as fistulas and abscesses, as well as assess areas of the small intestine that are not easily accessible by endoscopy. Treatment options for IBDs are broad and depend on the severity and location of inflammation, as well as the individual response to treatment. Aminosalicylates, such as sulfasalazine and mesalazine, are often used as the first lines of treatment for mild to moderate ulcerative colitis. Corticosteroids are used to control acute inflammatory flares, but their prolonged use is limited due to side effects. Immunosuppressants, such as azathioprine and 6-mercaptopurine, are used to maintain long-term remission. Biological therapies have revolutionized the treatment of IBDs in recent years. These therapies, which include monoclonal antibodies such as infliximab, adalimumab, and vedolizumab, target specific molecules involved in the inflammatory response. These therapies can induce and maintain remission in patients who have not responded to conventional treatments. However, their high cost and the potential for significant side effects, such as infections and autoimmune reactions, limit their use. Nutrition plays a critical role in the management of IBDs. During flares, inflammation can cause poor nutrient absorption, leading to malnutrition and vitamin deficiencies. Specific diets, such as the low FODMAP diet, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, have shown benefits in reducing symptoms in some patients. Enteral nutrition, where nutritional formulas are administered directly into the gastrointestinal tract, may be necessary in severe cases to ensure adequate nutrition and allow intestinal healing. Complications of IBDs can be severe and include intestinal obstruction, perforation, toxic megacolon, and an increased risk of colorectal cancer. Regular surveillance through colonoscopies is recommended for patients with long-standing IBDs, especially those with extensive ulcerative colitis, for the early detection of dysplasia, precancerous lesions. Surgical interventions may be necessary to treat complications such as fistulas, abscesses, and intestinal obstructions, or to remove severely affected segments of the intestine. The impact of IBDs on patients' quality of life is significant. Chronic pain, frequent need to use the bathroom, fatigue, and treatment side effects can negatively affect daily life, work, and personal relationships. Psychological support and complementary therapies such as stress management and acupuncture can be beneficial in helping patients cope with the emotional and physical impact of the disease. Ongoing research is crucial to improving the understanding and treatment of IBDs. Clinical studies are exploring new therapies, including new biological agents and small molecules, microbiome-based therapies, and dietary interventions. Personalized medicine, which aims to tailor treatments to the individual characteristics of each patient, is emerging as a promising approach to managing IBDs. Patient education and support are essential components in the management of IBDs. Patient education programs can help improve disease knowledge, promote treatment adherence, and empower patients to make informed decisions about their care. Support groups and online resources are also valuable for providing emotional support and sharing experiences with others facing similar challenges. Interdisciplinary collaboration is fundamental for the effective management of IBDs. This involves an integrated approach that includes gastroenterology specialists, nutritionists, specialized nurses, and other healthcare professionals. This collaborative approach ensures that all areas of patient care are addressed, from symptom control and nutrition to emotional support and long-term complication surveillance. Prevention strategies and early treatment are essential to reduce the impact of IBDs. Identifying individuals at risk through family history and genetic markers can allow the implementation of preventive measures before symptoms appear. Early interventions can slow disease progression and improve long-term outcomes. In conclusion, IBDs represent a significant challenge for patients and healthcare professionals. Despite the complexities of these conditions, significant advances in the understanding of etiology, diagnosis, and treatment have considerably improved patients' lives. Ongoing research and a multidisciplinary approach are essential to continue advancing the care of these chronic diseases and improving the quality of life for those living with IBDs.